But we are going to talk about prostate cancer survivorship. That's kind of the language that we use in the world of urology. September is Prostate Cancer Awareness Month. And so we figured this will be a good introduction or good little background of what goes on in the world of taking care of men after they've been through prostate cancer treatment. So we got a little disclosure here. Talks about, the materials and disclaimers. I am Marc Greenstein. I am a urologist in Sandy Springs, Georgia. I've been in practice since 2003, so I'm just starting my 19th year of practice. I moved to the Atlanta area about 4 years ago so that I could just kind of relocate the family and start something new and move on from the world of New Jersey. And it has been incredible ever since. I did my training in Philadelphia and went into practice for 15 years in New Jersey, and then moved down here 4 years ago. And it's been absolutely incredible being in Atlanta. I will say that. So let's talk a little bit of facts and numbers. So lots of people are diagnosed with, lots of men are being diagnosed with prostate cancer. You can see the numbers right on over here, 174,000. Of those men, a lot of them are going to go on and have prostate surgery. And then a lot of them are going to go on and have permanent incontinence because that's what happens. The dilemma is that a lot of these guys are afraid to go talk about it. They don't like to talk about it. Overall, lots of men suffer from stress incontinence. It's something that we see. It's not just related to prostate cancer. We see it from neurologic disorders. We see it from radiation therapy. We see it from pelvic trauma. We see it from other prostate ailments. So the number one cause of stress incontinence, though, is prostate cancer treatments. The two cornerstone treatments for treating prostate cancer are surgical intervention. In other words, we are going to take out the prostate, like it says right on over here. We are also going to be seeing it for radiation therapy. So we do a lot of radiation therapy for men that are not surgical candidates. But we also see some other things, like I mentioned before, pelvic trauma, scar tissue, neurologic issues, infections, prostate enlargement. That's another one that can cause stress incontinence after it's been treated and the patient's having some setbacks because things like that happen. So we kind of go by how do we grade the leakage? So the leakage is mild, moderate, severe, pretty easy. 1 to 3 pads is mild. Over 5 pads is more. Sometimes we ask patients to kind of weigh the pad. It's almost like the pediatric days when you can't do a intake and output on a 6-month-old, so you kind of weigh the diapers. The other test that I do for grading leakage is something called the cystoscopy stress test. So once they are, months and months after their therapy, everything's healed up, but they're still having ongoing stress incontinence, I will bring a man into the office, lay him down on our exam table. We give him an antibiotic, prep the genitalia, put some numbing jelly inside, and I take a flexible camera. They're awake. They are awake. I take a flexible camera and I look inside and I see what's going on with this anatomy. Is there scar tissue? Is there a blockage? What does the sphincter muscle look like? The sphincter muscle is the diaphragm of muscles that sit underneath where the prostate used to be or where the prostate still is to kind of clench down and close and open to help a guy urinate. And then once I do that, I look inside their bladder. I see how things look. I fill some water into their bladder as if they were drinking a big cup of coffee. And then I have them, and then I take the camera out, and then I have them stand up and I have them cough. And if they dribble a little bit, that tells me something. If they squirt right out, that tells me something else. So of the men that go on and have prostate cancer therapy, a lot of them are going to go on and have both erectile dysfunction and leakage. So we see a lot of these. We'll have guys that just come in randomly. They had prostate surgery at another center or another state or something, and they're cured of their cancer, but they're wearing pads and they haven't had an erection in a long time. So we do see that. And what I try to counsel guys in my practice before they have their therapy, and I saw 3 guys today like this, is that ultimately we need to fix you of your cancer. That's goal number 1, because people die of cancer. We don't want that to happen. I tell them that their urinary life is going to be very different, but it doesn't mean that they're committed to diapers, but it may be very different to them. And their sex life is not over. It may not be natural, but it doesn't mean that they have to give up on sex. So let's talk about stress incontinence a little bit. So stress incontinence means that the person walks, jumps, laughs, sneezes, coughs, and urine is dribbling out. If you ever want to see someone with stress incontinence, put them on a trampoline. Okay, I've seen that. Well, not personally, but they've come in and told me that story. So what can we do? Guys wear pads. It's uncomfortable. It's embarrassing. It's expensive. They have to go to Target all the time and load up on these things. There's something called a Cunningham clamp, where they literally, it's like a paper clip to the penis and it clamps. It's uncomfortable. It's awkward, but it can be successful for some guys. There is appliances that can be used to collect the urine. So there's something called a Texas catheter or a condom catheter. It's literally a condom, and then it just drips right into a bag. And instead of wearing diapers or pads, they just use something like that. Unfortunately, there is no medicine for stress incontinence. We can try to send them to pelvic floor physical therapy. I'm a huge fan of pelvic floor physical therapy. They can teach them biofeedback. They can teach them how to strengthen the pelvic floor. But sometimes that muscle is just kaput. It will not get any stronger. I saw a man the other day who's got very aggressive prostate cancer. He's young. He needs just a wide excision of his prostate, and he most likely will be incontinent afterwards. If he's not incontinent after that, he most likely will be incontinent after the radiation therapy that he most likely is going to need down the road, because some men need both therapies thrown their way. And then he's going to be a candidate for something like this if he wishes to pursue. So like I said, there's no medicine to make stress incontinence better. There is something called a male sling. So there's female slings, which is a mid-urethral sling. It's a sling that goes under the urethra in women. Well, we can do the same thing for men. And then the ultimate is something called an artificial urinary sphincter, which is this cuff that goes around the urethra. And then there's a pump that transfers fluid in and out of this cuff so that the patient can go to the bathroom. In other words, it acts like the muscle. So let's talk about the sling a little bit. Slings have been out for about, 20 years now. I remember when they first came out when I was a resident in 2001 and 2002, and they're basically used to act like a hammock to push up on the urethra and close it. And so that the normal pressures of the body are not strong enough to leak through the urethra because it's pushed closed. But when the person has to go to the bathroom and their bladder squeezes, it's enough force to get through the urethra besides that pressure from the sling. Very good success rate, 92% choose this. It is not meant for men with full-blown incontinence, like on the slide that they were up to 5 pads a day. It's better for men with 1 to 2 pads a day. It's an outpatient surgery, few weeks of recovery. The nice thing is that it works. It starts to work right away. In other words, once the patient wakes up, they start to get the healing process done, and they start feeling better. Erectile dysfunction. Oh, let me back up and talk a little bit about slings. Slings is also an outpatient surgery. I'm actually a huge fan of doing that surgery because it's really detailed, not microscopic surgery, but you're using you're working in a very small space, and I don't know, I find it rewarding. So it's 2 incisions. One incision is underneath the scrotum. One incision is on top of the pubic bone area. The reservoir goes on top in the pubic bone area. The pump gets pushed into the scrotum. The cuff goes around the urethra. Takes about an hour to do the surgery. They get sewn up. They go home. They heal up for about 4 to 6 weeks. And then at 6 weeks, we teach them how to literally turn it on. And they find this pump that's in the scrotum. They squeeze it. And what it does is it pushes fluid out of the cuff and into the reservoir. The cuff opens and the patient starts to go to the bathroom. And then over time, the cuff slowly closes down. So the fluid in the reservoir automatically comes back into the cuff. The cuff slowly closes. It squeezes down on the urethra. It's firm enough to prevent urine from leaking down. Patient goes about their business. Their bladder starts to fill. When they get the sensation to have to go to the bathroom, go to the bathroom. Once again, squeeze the pump, and the cycle starts all over again. So let's talk a little bit about erectile dysfunction. Like I mentioned, for men, this is not the end of their sex life. We don't want this to be. It's kind of interesting when guys come into the office. A lot of them come in with their partners, their wives. The wife or the partner is usually saying, I need him alive. I still like him. I want him not to go anywhere. And the patient is usually like, what about my erections? What about my erections? What about my erections? And that's kind of what we see. So what are some options that we can do for erectile dysfunction? Lifestyle changes, lose weight, eat well, get a good night's sleep, take good care of yourself, part of survivorship. We love medicines, Viagra, Cialis, something called Levitra. Well, they're all generic these days. There's a medicine called Stendra. Muse is expensive. This is this little tablet. So picture a little tablet on the end of this little suppository here. This goes into the urethra. The patient would push this plunger down, and this little tablet gets pushed into the urethra, and then they kind of roll it around like rolling bread or rolling dough, and it absorbs over a few minutes into the urethra. And it should stimulate blood supply to the penis. It's a medicine called prostaglandin or Prostadil. Problem with Muse is that it's very expensive and it can cause a lot of irritation of the urethra. There's also topical gels that are out there. The gels get squirted into the urethra and they try to do the same thing as Muse, but once again, very expensive and they cause some urethral irritation. Vacuum devices, let's be honest, let's see if we can suck the blood into the penis. So they could be handheld, they could be battery powered. They put a little gel on the bottom of the pump. The pump gets placed over the penis and literally pump it up. Some guys need a restriction ring that will go down on the base of the penis to keep the blood in, because otherwise that blood may go right back out. And then the other thing that we do a lot of is injection therapies. Our protocol here is to bring people into the office. They go into our ultrasound room. We look at the blood supply to the penis. My ultrasound tech then does a tiny injection of a medicine called Bimix or Trimix. This is a combination of medicine that stimulates blood supply to an organ. We do it in other parts of the body for other issues, but for us, we do it into the penis. So it's this little itty bitty needle. It's like a little quarter inch needle. And 10, 15 minutes later, that patient will have some kind of an erection. The tech goes back in, they re-look at the ultrasound, they look at the arteries, and they look at the veins. The reason we look at the veins is because when a guy gets an erection, blood goes in, the tissue expands, and the blood should get trapped, and the veins are closed. That's the trapping. But when men have radiation therapy, diabetes, strokes, pelvic surgery like prostate surgeries, those veins become dysfunctional. They don't work. They stay open and the blood goes in, the blood comes right out. We call it a venous leak. So when we have patients where medicines are not working, injections are not working, or injections are uncomfortable, the next step is the penile implant. I will tell you, we love doing penile implants around here. The reason for that is because when you take a man that has not been able to have sex in a year or 2 or even 5 years, and then you do a surgery on them and they recover well, and then they start having sex again, they're going to come back with a big grin. Implant surgery is outpatient surgery these days. We do it in our surgery center. We can do it in the hospital. And there are 2 kinds of implants out there. There's actually a third. I'm not going to talk about it right now. The easiest one is called a malleable. So it's basically these cylinders that go inside the cylinders, because the corpora are cylinders of the body, and they're always up, but they're malleable, they're bendable. So they're down, they're up, they're down, they're up. Easy. Good for patients with bad dexterity. In other words, they can't use their fingers. Patients with higher risk of having longer surgery or more devices put inside them. And so we like these for certain individuals. But the ultimate, we'll call it the Cadillac, if you want to call it a Cadillac, the Rolls Royce, is a 3-piece or an inflatable penile prosthesis. And that's a surgery where we pump up our inflatable cylinders inside the corpora. There is a pump that goes inside the scrotum. And then there's a reservoir that goes next to the bladder. There's a couple of approaches for this. There's something called an infrapubic approach. There is a subcoronal approach, and there's something called a penoscrotal approach. So the infrapubic approach, the incision is made just above the penis. The penoscrotal is done at the junction of the scrotum and the penis. And then there are some doctors who will actually do something right underneath the corona, which is the glands of the penis. 1 hour, usually surgery is anywhere from 30 minutes to an hour, depending on the surgeon and the patient. And then they go home and they start their therapy. And I describe it as washing your hair, because that's what I do all the time. And so it is lather, rinse, repeat. Ice, antibiotics, pain meds. Ice, antibiotic, pain meds. The patients will be uncomfortable for a while. They're sore for at least a week, if not 2 or 3. There's definitely some swelling, but it gets better. And it's a surgery where it really has 88% of pumps are working at 10 years. Satisfaction rate is very high. Like I said, we get these patients that come back in and they're happy. They feel like a man again. They feel good. They are satisfied. So why do we want to do this for people? Well, men are mammals. Let's be honest. They need to eat and they need to have sex. And that's just kind of what it is. It's almost like watching, Animal Planet on Discovery Channel. Men who are not sexually active, men who are constantly worried about their leaking and wearing pads and diapers. You can see the side effects that we see here: anxiety, anger, relationship issues, depression. Men need to go to therapy sometimes. We work very, very well with a group of sex therapists in the Atlanta area, because they see a lot of men that have sexual dysfunction after their prostate surgery. And these guys need to know how to get back into the saddle. They need to work with their partners, their wives, their mates, so that they can be together again. Now, there are some guys out there with their couples, and they're good. They're done. They don't need to be pushed. They're comfortable with where things are, and we are just here to help. We do a lot of symptom scores, a little bit because they're validated. Insurances like it. They're published, and they've been able to show that we can get them better. There's something called a shim test. There's something called an IPSS score, things like that. And so we screen these men for these concerns. What can you do from a physician assistant and a nurse practitioner point of view? Don't be afraid to ask them questions. Most guys are not going to want to talk about this until they're just fed up with it. But we find that if you just have a quick little, how are you? How's the control? How's the erections? You should be able to get a little bit of something out of them. And this is even for men who don't have prostate cancer. We see other things that go on here. We see plenty of guys with diabetes and strokes and prostate enlargements and things like that. And A lot of guys are very afraid to talk about it. We can call it like a door handle syndrome. In other words, they'll say, oh yeah, I thought I had a kidney stone last week. I had some pain, so I wanted to come in. And I check them out. I do my thing. And I'm like, is there anything else you want to talk about? And then they're like, no. And then I grab the door handle and I'm ready to walk out. And they're like, by the way, what's this Viagra thing? And I'm like, okay, here we go. It's out there. Let's talk about it. So don't be afraid to talk about it. They don't want to talk about it. They don't want to talk about it, but you should not be afraid to talk about it. And that's basically a lot of things that we do around here of helping men, for this specific talk, helping men after their prostate cancer treatment. Like I mentioned, we call it prostate cancer survivorship. This is one little thing that we do. We also make sure that their PSAs are okay. We make sure that they're eating well, sleeping well. We make sure that they're following up with their primary care physician, getting their cholesterols checked, their vitamin D levels, their blood pressures are checked. And that's what we got to say. If anybody has any questions, I'd be more than happy to take some questions. I got a little video I want to show. Let me back up. Hold on. I do have a little video. Let me see if I can get this to work here. Excuse me. I hope this sound is going to work. If there is no sound, I'll just talk. So reservoir, cylinders, pump. So once a person is good and healed, they find that pump. The fluid gets transferred from the reservoir into the cylinders, and up he goes. He does his thing, if you know what I mean. Not to sound juvenile, but he does his business. And then on top of the pump, we'll call it like a release valve. They squeeze it. They squeeze the penis. The fluid then gets pushed back into the reservoir, and they're down. They want to have sex 10 minutes later, have sex 10 minutes later. They want to have sex the next day, they have sex the next day. So the nice thing about the implants is they don't have to worry about timing. They don't have to worry about, is a medicine gonna work? Is an injection gonna work? Is it gonna hurt? Things like that. And so it helps with relieving some of the concerns and dysfunctions that happen with Viagra that doesn't work, or injections that don't work, or the vacuum device is too awkward. So at this time, like I said, I'd like to open this up to some questions. Please let me know if there's anything I can help you with. All right, here's a good question. I thought of this, it's not put here, but let's ask a question. Is it covered by insurance? So Medicare pays for implants. And so we're good to go with that. And so that's a nice covered thing. Some insurances do not carve out implants for their patients, but we find that if we can identify a certain problem within that coding of the insurance company, it can get covered. So for example, if a person has diabetes and the diabetes affects their erectile dysfunction, that can get covered if we use a certain code. Venous leaks, also, that can get covered if we use the proper codes. As far as the sphincters go, I don't think I've ever seen a situation where it's not covered. So I think that's not something we have to worry about. Insurances always tend to look at erectile dysfunction a little differently. They usually don't want to take care of that because they think it's a quality of life thing as opposed to a life thing. They're more than happy to give you all your blood pressure medicine, but they don't want to help a guy have intercourse. All right. I got one. What type of diet would you suggest for current and post-prostatectomy patients? All right, so there is a couple of books out there that I reference when I see patients that are in their active treatment and also their survivorship treatment. One is by a doctor named Marc Moad. Marc Moad is a, let me see if I can do something here. It's going to be hard to type. Marc Moad, Moyad. And he's a urologist out in Michigan that really, I don't think practices urology anymore. He does mostly nutrition and nutraceuticals. So the important thing is low-fat diet, keep your cholesterol under control, get vitamin D in you. You can't eat fast food. There's things out there like selenium and vitamin E that I promote to patients. We used to think of these things, that the selenium and the vitamin E, is like a magic bullet. It really isn't, but we want to make sure that they are, they're kind of part of their process. But we find that if men are keeping their weight under control, keeping their cholesterol under control, keeping a good vitamin D level, those guys have a better chance of preventing their cancer from coming back than from someone where they have high cholesterol, poor vitamin D, lots of fat in their diet, things like that. If I look at my men that I've biopsied over the years and they are negative, because we do a lot of biopsies and we don't find cancer, I will tell you 60% of them are on a cholesterol medicine. And that is very well looked at, very looked into for men, that statin medicines are good for protecting the prostate, just like they are for protecting the heart. So if you think of something as good for your heart, it is good for your urinary system and for the rest of your body. So I hope that answers your question. I have another question here. Does this work for patients post-stroke? Yeah, so cerebral vascular accidents, strokes, are a very common cause of erectile dysfunction. So you got to figure, if they're having bad blood supply to the brain, they're having bad blood supply to their heart, they're having bad blood supply to the penis. The dilemma with stroke patients is, how's their dexterity? Did the stroke affect their ability to use their hands? Because if they can't pump up a device, it's hard to put a penile implant in them. Now, they may have a person they're having sex with that can do that for them, and they can pump it up. I've seen that before. All you need is one hand. So if they became hemiplegic, you can always use one hand. But another option would be to use the malleable, because like I said, it's up, it's down, it's up, it's down. No dexterity whatsoever. Hope that answers your question. Anything else? Let's see. All right, well, we are getting close to 7 p.m. and I've got tons of notes to do tonight, because that's how it works. I'm sure a lot of people can understand that. And so if there's anything I can help you with, you're more than welcome to reach out to the Coloplast team. And I want to say thank you for everybody for putting this together tonight. And hope everybody learned something. And the other thing I'm going to ask my APPs and my nurse practitioners to do, please do not forget to do prostate exams. I don't know what is going on in the world. Actually, I know what's going on in the world. You cannot go just by the PSA. I saw 2 people in the last few weeks with normal PSAs and rip-roaring prostate cancer, life-threatening prostate cancer. Please do an exam. Please examine your patients, all right? And if you're not comfortable examining the patient, send them to the urologist to get screened, please. And have a good night, everybody. I hope this helped.